Hello, I'm Dr. Kim Kyung-won. Today, we begin the lectures of master course surgery. Often when we place an implant in the upper posterior region due to maxillary sinus, residual alveolar bone is not sufficient, so bone graft or additional sinus surgery would be required. For the successful surgery, we need to understand the maxillary sinus structure and morphology, anatomy, and physiology. So in this and next lectures, I'm going to talk about the maxillary sinus anatomy and physiology in more details. First, I'm going to talk about the overview of maxillary sinus and sinus walls. As you know, maxillary sinus is a type of paranasal sinuses. So the paranasal sinus, as you know, has maxillary sinus, frontal sinus, ethmoid sinus, and sphenoid sinus. The four sinuses are in pairs, the left and right, so in total of 8 sinuses. Features of maxillary sinus. It is the largest sinus in the paranasal sinuses. In terms of the shape of maxillary sinus, it's a pyramidal shape of 5 thin bony walls. And in terms of the volume, it differs from person to person, and it's different from left to right. In a person, the average capacity of Korean people is about 15 cc. If upper posterior teeth are missing, pneumatization can occur, as you know. And in the maxillary sinus, a septum or other compartments can make the maxillary sinus surgery difficult. Let's look at the growth of maxillary sinus in general. In terms of the embryo, 3-month-old embryo, about 3 months of fetal development by unpouching of nasal mucosa. From birth to 3 years old, they have the first rapid growth period, followed by the second rapid growth period at about 6 years of age to 18. The maxillary sinus floor and nasal cavity floor have the similar height. And after the growth is finished, in most cases, permanent tooth would be coming out. The maxillary sinus pneumatization extends up to 5 millimeters inferiorly to the permanent root. So the maxillary sinus expansion, as I said before, corresponds to the growth of midface, and the growth is completed at around 18 years of age. Let's have a look at the maxillary sinus. If you look at here, there is an inferior turbinate bone. The bone is indicated in white, ethmoid sinus, and superior turbinate bone, and the middle turbinate bone are indicated in the color blue. As we learned in the anatomy class, inferior turbinate bone in the skull is an independent bone. However, superior and middle turbinate bones are part of ethmoid bone. So in general, maxillary sinus and nasal cavity are connected in the orifice of maxillary sinus, which is between the inferior turbinate bone and ethmoid bone. So because of that, in the nasal cavity, the middle nasal meatus, the middle layer, is connected to the maxillary sinus. As I said before, actually, the size of the sinus is different inter-individually, and there is a difference between the left and the right in the same person. So the shape and size should be checked using the X-ray. As I said before, the shape of the maxillary sinus is pyramid, in general, the pyramidal shape, the base is in the nasal cavity side, and apex is in the zygoma process. The pyramid is lying in the sideway like this, but I explained to patients that it is positioned upside down. That's easier for the patient to understand. So maxillary sinus is in the shape of a pyramid. The average size of that is about 40 millimeters in height and 35 millimeters in width. As I said before, the average volume is about 15 cc. Sometimes we get this kind of question. For maxillary sinus bone graft, what is the amount of graft? It depends on the size of the sinus and the width of the sinus. However, based on Korean population, if we are talking about to place 2 to 3 implants in the upper posterior region with the bone graft, 2 cc would be enough. That will make the bone graft fill up to 10 millimeters from the floor of the sinus. In my case, I do about 2 cc bone grafting. Next, maxillary sinus walls. As I said before, maxillary sinus has a shape of pyramid, and there are 5 walls: anterior lateral wall, medial wall, posterior, superior, and inferior walls. In general, anterior lateral wall is in the distal side, so it is called a lateral wall. In the lateral wall is where we make a window for lateral approach. Normally, thickness of the lateral wall in the maxillary sinus is about 1 to 2 millimeters. The thinnest part is between the second premolar and the first molar. In general, that is the thinnest portion, so usually it is where the window is made. And the thickest position is between the first and the second molars, and that part is where the zygomatic buttress is coming down. There's a zygoma process, and zygomatic buttress is coming down from the process, and that part is between the first and the second molars. Usually, that's the area where the maxillary curvature is observed. So it's between the first and second molars. The lateral window can be easily made in the mesial of the first and second molars. Between the second premolar and the first molar, if the second molar is missing, number 7 is missing, it is distal to the zygomatic buttress. So sometimes it can be very difficult to make a window there in some patients. For some patients, it is easy, but in general, between the first and the second molars, the thickest part, zygomatic buttress, comes down and there's a curvature. In the mesial to that, a lateral approach can be easily done, but distal to that, it is difficult. So, in the lateral wall, the thickness of the wall needs to be determined based on the coronal view of the preoperative CBCT imaging. We need to accurately, in advance, estimate the thickness of the lateral wall. Next, medial wall. It is in the medial side, so that is a lateral wall of nasal cavity. As I said before, there is the inferior nasal concha, and there is the ethmoid bone. So like this, the base of the sinus, the base of the pyramid in the medial wall, the most important part is the maxillary sinus ostium. Simply put, it is an opening for drainage to go to the nasal cavity. As I said, it is an opening between the inferior turbinate bone and ethmoid bone. The uncinate process and other structures exist which make an access very difficult, but basically it is an opening between the ethmoid bone and inferior turbinate bone. The ostium of the maxillary sinus is the most important structure when it comes to the physiological function in the maxillary sinus, which will be discussed in the next lecture. So the maxillary sinus ostium, if you look at here, when the middle turbinate bone is cut off, it is between the middle turbinate bone and inferior turbinate bone. That means an opening between the ethmoid bone and inferior turbinate bone. The position, roughly, it looks like a tube, and the length is about 3 to 5 millimeters. From the inferior maxillary sinus, it is 4 centimeters above that, and it is in the middle of the maxillary sinus, so 2 centimeters from the front and 2 centimeters from the back. So if you want to access the maxillary ostium through the lateral approach, remember that it is pretty high up there. The maxillary sinus ostium is the route for mucociliary clearance to transport the secretions from the maxillary sinus to nasal cavity. As I said before, it is between the inferior turbinate and ethmoid bone for the drainage to the middle nasal meatus. Next, posterior wall. It is in front of the pterygoid plate. During surgery, I don't think you can easily access there, and you don't really need to go there as well. Next, the superior wall of the maxillary sinus is the floor of orbit. The infraorbital nerve and vessels exist, which are important, and they are high in the eyes. So during surgery, I don't think you will touch or invade that area. The superior wall of the maxillary sinus, there's infraorbital canal where vessels and nerves pass. Next, inferior wall. It is the maxillary sinus floor. It is usually 10 millimeters inferior to the nasal floor. So that is the position. The accurate position should be checked using the coronal view of CBCT for the exact location of the sinus floor, but usually it is about 10 millimeters inferior to the nasal floor. The thinnest part of the inferior wall is near the second molar, especially for immediate placement after extraction. If there is a tooth, it is difficult to measure the height. So it is a difficulty when you try to do immediate placement. The inferior wall, the relationship of vertical position with the maxillary molar root. Type 1, it is a little bit above the root. That is the most commonly found cases in Korea. If you combine type 1 and 2, including 5 millimeters below the root, it makes up 80%. So in most cases, the height is similar or higher than the remaining root. Next, the relationship of horizontal position with maxillary molar root. In general, in 80% of the cases, it is in the buccal side or in the middle. So the lowest part of the sinus floor is usually in the buccal side rather than the palatal side. Therefore, you do not have a lot of difficulties in accessing the sinus floor. If you look at the shape of maxillary sinus floor, coronal view, the U shape, you have this wide type or V shape, a narrow shape. So in general, if it is wide like U shape, bone graft would be difficult just using the crestal approach, but prognosis is better when it is a V shape with a crestal approach. If you look at the lateral view of the sinus floor, there are three. The easiest access can be done for the flat type, and C, the irregular one is found when an extraction is made recently. In that case, when you access the floor, perforation may occur. Next, if there is a high septum, when you do the surgery, that can pose some inconvenience. Septum can exist in the sinus floor. It causes irregularity of inferior margin of bony crests in the sinus, which causes some problems. Here in the panorama view, zygoma buttress exists bilaterally, and there is septum, a rather high septum in this patient. In this case, if you take CT images, depending on the coronal section, depending on the septum position, the images may look different, and you need to look at various images of the septum to understand the anatomical structure accurately. In this case, axial section, 2 or 3 compartments are observed, or they are combined together, depending on the axial view. The septum has advantages too. When you place an implant, it can provide more bony surfaces for osteogenesis. That's an advantage, and it helps the implant stability. However, in general, the septum works as a disadvantage, especially for a lateral approach. If there is a septum, it can pose a problem in creating a window. And septum also can be a problem with the crestal approach. Sinus perforation can easily be made. This case you already saw. The patient didn't want the extraction of the impacted number 8. A window is created, and you can see a septum here. Because of the septum, the sinus membrane can easily be perforated. Another case, in this patient, premolars and molars are missing. So between the premolars and molars, you can see a rather high septum. So 2 windows are made in premolar and molar areas to do a sinus surgery. A window is made first in the premolar area, and later another window is made in the molar area due to the septum in the middle. Maxillary sinus mucosa is perforated. When maxillary sinus is perforated, the surgery can be delayed, and at another opportunity, when sinus membrane is perforated, I will talk about how to repair it. When there is a septum, when you do the lateral approach, it can be a problem. Pneumatization can occur. The loss of maxillary posterior tooth is inevitably concurrent with pneumatization, and the maxillary sinus is enlarged, and the inferior wall thickness becomes thin. So with the pneumatization, lateral wall tends to get thinner. Let's look at cases. In this patient, the height of the sinus floor is similar to that of the nasal floor. If you look at the shape of the floor, there's a difference between the left from the right. This is a young patient. Bilaterally, the second premolars are congenitally missing, and the second deciduous molars remain. When teeth are missing like this, pneumatization can occur a lot. Next, a more extreme case. In this patient, on the right, the second premolar is missing and the sinus floor came down. In this case, even canine roots are involved in the sinus, so the sinus is occupying all the maxilla, which is not very good for implant placement. So we have talked about maxillary sinus characteristics and types of maxillary sinus walls, 5 of them. The medial wall, the most important structure is the maxillary sinus ostium. It connects maxillary sinus and nasal cavity. And lateral wall, anterolateral wall, you need to check CT images in terms of the thickness of the lateral wall for ease of surgery. Inferior wall. If you have a septum in the sinus floor, you need to identify the location and the shape of the septum. That will help the surgery. I talked about the maxillary sinus, the simple ones. When you place an implant in the upper posterior region, the sinus can pose as a barrier. At the beginning, it may seem to be a challenge, but if you study the theories through the master course and if you challenge the cases, you will be able to get skilled in that. And this concludes the first lecture. Thank you for your attention.